Good morning. This is Dr. Badia. Welcome to another week of Fixing Healthcare from the Trenches. I have the utmost pleasure to introduce our guest today, who is not only an exceptional surgeon, a pioneer, but really a good friend. He's the first fellow hand surgeon that I interviewed, is Dr. Jean-Paul Brutus, who's coming to us from Montreal, a different healthcare system. Correct, Jean-Paul?
Yes. Good morning. Thank you for the introduction.
Yeah. So a little background on Dr. Brutus. He has a private practice in Montreal, which we'll discuss shortly. Exception MD. He's a founder of the Exceptional Care Network, of which I'm honored to be a member of, like-minded hand surgeons who really believe in customer service. We getting a little feedback there?
You're good.
Okay. So he's an adjunct professor at the University of Montreal. He did his MD at the University of Brussels. So JP is a Belgian surgeon living in Canada. He did his plastic surgery residency at the University of Montreal and a fellowship at Upstate in New York, an excellent program that was founded by a friend of mine, Andy Palmer, now retired hand surgeon. He's also written 2 books, so he's not going to. I'll have to tell the audience that I really enjoyed one of them. If you like juicy stuff, it's called Secrets and Lies from the Operating Room.
Who doesn't like secrets?
What's that?
Who doesn't like secrets?
Oh, who doesn't like secrets? Yes, that's right. He's also a proponent of Volant, which we'll get into, which is an acronym for wide awake, local anesthesia, no tourniquet. And I saw my colleague Don Lalonde, who's also from Canada, who really started this because of necessity. And we'll talk a little bit about that. So I want to introduce here essentially the first real private practice hand surgeon in Canada, and we're going to talk about why. Why did he decide to buck the trend for his patients? So welcome, JP.
Thank you. Thank you very much for having me. I've been indeed running a private practice in Canada, doing exclusively hand surgery for almost 15 years now. I used to be in academic practice because my passion was to teach hand surgery to future plastic surgeons and develop new technologies, use minimally invasive techniques for which I was, that's the reason I was recruited by University of Montreal at the end of my fellowship with Andy Palmer in New York, in Syracuse, New York. And so initially I had an academic career. And as you know, Canada has universal healthcare. So that means healthcare is paid by taxpayers' Canadian dollars. And so patients don't have to pay anything when they seek medical care, which is good in theory. But as was to discover, it comes with a lot of limitations in terms of, access to human resources, nurses, operating rooms, and also technology. So paradoxically, they had recruited me to do minimally invasive techniques, but they wouldn't provide me with the equipment that I needed. And so I was encouraged to reapply the next year, which I did. And again, next year, hoping for a new budget and this and that. And because I'm a slow learner, it took me 5 to 6 years to realize this was never going to happen. And so, and because I was one of the very rare hand surgeons per se, my practice was booming. I had way too many patients that I couldn't help. And I tried to go work in different hospitals at the same time to get access to more resources so I could, find solutions to help all these people. But I realized the number of patients I had under my care just exploded. So I created a bigger problem by doing that. And often when you try to solve a problem, you end up creating a new one. So you want that new problem to be of better quality than the previous one, which wasn't the case. So in the end, I realized I started to become resentful of the situation, and I started, wondering if I still liked my job. And after investing so many years into this training, it really bothered me. And then it dawned on me that the problem was not the job. The problem was not the career. The problem was the environment. And
The
so
system.
the system,
Right?
yes.
Yeah.
I was hitting a wall in, every time I wanted something or I needed something from my patients, not from myself, but from my patients. So in the end, I decided, I can't do this anymore. I have to leave. And so that's when I decided to go private. And to be honest with you, most my colleagues thought I was crazy because they said to me, there's no way Canadians are going to pay for private hand surgery. It just doesn't happen. I mean, there's only one thing that's more Canadian than universal healthcare, and that's hockey. So, so being a little bit of a what would you call it, an international rebel, I decided, you know what, I'm going to try. I'm going to give myself 1 year and see if it works. And then there were two types of colleagues that I had: those who liked me and those who didn't. Those who liked me said, we understand why you need to do this. When you fail, you can always come back and we'll save you a spot. And then there was the ones that didn't like me too much and said, we're going to watch you crash and burn. So I went, and it's been almost 15 years now, and it's been growing ever since, because mentalities are changing in Canada, because Canadians realize that when it comes to non-emergent medical services, there's just wait times, and it's becoming a big problem. And of course, the COVID-19 pandemic put fuel on the fire. Right. And so the wait times have exploded for example, elective hand surgeries or joint replacements and that kind of stuff. So since then, it's just exploded. And this is why we're having this conversation today.
Well, I mean, look at what's happening to the NHS. In England, for our American viewers, the public health system, which was always the pride of England, is called the NHS, the National Health Service, and they're having problems. In the end, I mean, even in medicine, you get what you pay for, and the problem is there is an explosion in technology, and these things are not free. And we have to make a decision as a society. Is it worth, we both do a lot of treatment of the basal joint, right, of the thumb, right? I mean, is it worth paying something for a little prosthesis that lets you move right away? Or are you going to stick with the traditional techniques? And the people like yourself, JP, or like our exceptional care network, are people who really go on the fringe. But these things are not cheap, and we have to realize you're a plastic surgeon, right? I mean, it shouldn't just be cosmetic surgery that people open their wallet for, right? No. We have to change that mentality, and that's very difficult, isn't it?
It is, but it is changing. I mean, yes. I think in the United States, it'd probably be easier than it is in Canada, but I can see it changing in Canada. I mean, I've been here for almost 20 years now, and I can see that year after year, more and more people go straight to direct pay-for-service private care because they want access, number one. They want to be able to schedule their surgery, for example, around their own schedule and their own lifestyle. Because just to give you an idea, if you go to a Canadian hospital for, let's say, a carpal tunnel syndrome that needs surgery, okay, you wait 6 months or more to see the hand surgeon, and then you go home and you wait for the phone call, and you don't know when that phone call is going to come. It could be in a year, could be in 2 years, you have no idea. So you're trying to live a life, and then one day, you may get the phone call telling you it's tomorrow. It just doesn't work. So people come for convenience of being able to plan their lives, which you want to do when it's not, life or death. Number two, they want better techniques. They want access to innovation for, less downtime, faster recovery, and all of that. And also, don't forget, they want to be able to choose who's going to operate on them, which is something you can't do in a universal care system, because you're going to see whoever's there. And sometimes the surgeon you meet in the hospital after waiting for 6 months or more, sometimes it's not the surgeon who's going to end up doing the procedure, which is outrageous. My hair is quite short and easy, but I have one hairstylist that I go to, and I don't want anybody else. It's just hair. It's going to grow back. Yeah. So imagine having surgery with somebody you don't even know.
I blame the public for some of this too, because you see it. I mean, they're willing to do this for, say, as I said, aesthetic surgery. But I think the public has to wake up and realize that healthcare, especially elective care, is something that that should be more valued. And we just assume that these insurance companies, take care of you, or the government takes care of you, like in the UK or in Canada. And we're seeing that's not the case.
No.
If you recall, JP, I went up there and by the way, I saw Dr. Brutus's practice. It's amazing. It's very focused on patient, like customer service, as it should be in healthcare. Extremely pleasant environment, beautiful aesthetic office. But I went up there and visited you, and I gave some lectures at that hand surgery meeting on sports injuries, if you recall. And I had dinner with you and one of your old partners,
yes,
who told me he was doing the same thing because he did mostly shoulders, correct?
yes,
And remember, by the time when he saw a patient in the public system, by the time it was approved, the rotator cuff tear was irreparable. In other words, you would go in with the arthroscopy and you could not repair it. So there is an economic consequence of waiting. I mean, let's talk about cancer. You get diagnosed with a cancer, you can't wait to have that, surgical removal or to begin chemotherapy. But even in hand surgery or upper limb surgery, there are major consequences to function. And function is important to make a living. So all these things are tied together. And I think the public and social media gives us the opportunity with platforms like this and so many others to be able to talk about this and get the public finally interested in this and talking about it, whether it be in Canada, the UK, or the United States, where I'll soon be asking you specific questions because you did work in both systems, right?
yes,
You saw how it works in Syracuse, New York,
yes,
and obviously now in Montreal and in Belgium.
yes.
So it'd be interesting to hear your perspective.
Yes, but you couldn't be more right when you said that we got to get the public on board, because the public doesn't know, and the public has been too trusting of the authorities and the government, particularly in Canada, because of the way the system is organized. And a system does not change unless it is forced to change, even if it's in its best interest sometimes. So I think the momentum to create that change is going to come from the public saying it's enough. Now we deserve to get what we pay for, because don't forget, healthcare in Canada is not free. We pay.
No, nothing is free, right? Ultimately,
25 to 50% of the money coming from income tax in Canada goes to healthcare. It's massive.
Wow. Right.
And if you think about it, what do you get in return? The return on investment is not too good.
Yeah, the problem is they have to, the system, whether it be in the U.S. or Canada, has to speak to those of us who are in the trenches. You have these bureaucrats, administrators, and obviously we need that. I'm friends with some excellent administrators in healthcare, but the truth is there needs to be more dialogue with us, the people who are actually delivering that care.
Absolutely, and I think doctors and physicians need to get more involved
Together.
in leadership positions to influence policies, because it feels like either doctors have been kicked out of, or they have relinquished this
care, this control.
Yes, and now it's being controlled by people who don't really care about patients. They care about numbers, they care about budgets, they care about profits. But doctors have taken an oath. And by nature, when you go into medicine, it's because you care about patients, and we want to put patients' needs.
Right. Well, we're taking advantage of. You see what's happening in Spain. I just posted this in Seville, Spain. The physicians are finally on strike. Other than major emergencies, they are on strike because they have not had a pay raise in 30 years. I mean, what has happened to the world economy? I mean, right now in the U.S., it's 8% inflation, and worse. So you're right. It's time for physicians to collaborate. So I want to ask you, this is the time in the podcast where I'm going to ask you three, right off the top of your head, three different suggestions as to how we can really radically change healthcare delivery and improve it and make it more cost efficient.
Thanks for the easy question. I'm going to solve American healthcare in 3 minutes. So when it comes to my specialty or our specialty, I believe what I'm doing here is living proof. I believe elective hand and orthopedic surgery, like hand surgery, elbow surgery, shoulder surgery, knee surgery, hip surgery, all that stuff, should be taken out of hospitals when the patients are healthy. Why? Because ambulatory care centers, ideally not owned by for-profit organizations, by the way, can deliver care better, faster, and cheaper, much cheaper. So that would be one thing.
So number one is go move to outpatient care, which we saw during the pandemic, right?
Yes. Yes.
Most would agree with that. Okay, number two?
Yes. Number two would be, that's a delicate one, but I believe the way doctors are paid, the fee-for-service structure doesn't make sense anymore, because it just encourages more volume, more activity, but not necessarily for better outcomes. So, for example, what we do here is when somebody comes to see us for a surgical solution to their problem, the quote that they get includes the surgery, includes anesthesia, includes everything, the implants, all of that, plus unlimited follow-up for 2 years, for example. So no matter what happens for the next 2 years, it's all included. So it's a way of bundling it that makes it very easy for the patient to know, okay, it's going to cost me this much, and there's not going to be surprise bills. That does not exist in the U.S. system mostly.
Well, but it's changing, because if you're out of network, that's kind of a myth. The insurances are no longer really honoring that. So this is another way that they're hoodwinking us. So in my practice, which you visited several times, right, JB?
Yes.
You've seen that, where patients come and say they have arthritis in the base of their thumb. I mean, they're going to get a price. They're going to know upfront that includes the surgery center down the hall, our fees from my office, right? This is not free, right?
Yes.
Anesthesia and the implant, and I like that 2 year. I think I'm going to institute that, the 2 year rule. Anything. Well, we do it. I recently operated on somebody I had to bring back to the OR because I had to repin one of the joints, and I asked the OR. I said, look, let's not charge this gentleman. He already paid. It's not that anybody made a mistake. It's just this is part of healthcare, right? So I think that's great. I mean, almost like bundle payments, right?
Yes, exactly. So I think that would be another way. And
number three.
The third one is, I think I alluded to it, but I believe healthcare facilities, whether they're hospitals or homes or surgery centers, I don't think should be owned by for-profit organizations, because
I say that in my book.
It makes
Absolutely.
sense to make profit over someone's health, because the best way to make more money is to deny care. So
right.
It just doesn't work. So I think
I think the best way to make money is to be more cost efficient, right?
Yes.
Provide so we got your three. So I'm gonna because of time, I'm gonna give you my three very quickly. So first one is right clinician at the right time, meaning you got to see the right medical specialist. There's too much knowledge, a body of knowledge out there. It's impossible for any physician. I always believe that primary care doctors need to keep us healthy, need to monitor our care.
Yes.
But the second you have wrist pain, you want to see somebody who knows wrist. Why? Because they're not going to order an MRI, right, JP, for a decorative veins tendonitis. Exactly. Right? That's an expensive test.
Or ganglion cyst.
Or ganglion cyst, right. Yeah. So the second one would be oversight, not authorization, meaning that it's okay that the insurance plans and or the government, what have you, keep an eye on us, make sure there's no outliers, make sure people aren't doing something incorrectly or excessively, but don't make us have an authorization number every step of the way. You have to pay that person who's sitting at a desk who doesn't know anything about the wrist, and you're just adding cost and delays. So that is my second one. And then the third one is what we're doing. Public education.
Yes.
Podcasts like this and many others. The book I wrote, Healthcare from the Trenches, which mentions some of the things, including insurance companies going, like in one country, which I will not mention. There is one country in Europe, which is an excellent model for healthcare, where they have competition for insurance companies, and executives can make a lot of money as CEOs of, but it is not for profit. So they have to compete with efficiency.
Is this country known for its chocolate?
No, definitely not.
Okay, so I agree. Yeah. And I would add to that, remind physicians that they have a voice. And
Yes.
I think physicians have been too silent for too long.
We're seeing that in Seville, Spain now. So everybody who's listening, look into that. I want to let everyone know that the recording of this will be up this afternoon. So please share it, because for us in healthcare to collaborate, we have to know what the issues, and we have to support each other in bringing this to the public.
We have to know that we're not alone doing this, right?
Right.
And
exactly. And we're doing this for our patients, for society. Yes. I mean, in the end, you and I are in the same boat, right? We're sort of in that private practice. We care about healthcare in general in our countries. I mean, we absolutely do.
In my case, it's more than one country. I care about 3 countries.
Yes, right. You do. Yes, you are a Renaissance man, JB.
Yes,
absolutely. So, I want to thank the viewers. You can catch this now. The podcast is now moved, and will also be on Twitter, Facebook, YouTube, and LinkedIn. So we will see what kind of response this has. And I'm so happy, JP, that you are our first guest on this wider platform, because we really have to get the message out. And the first thing you said when you came on was that the physicians, we need to collaborate. That we need to get together
behind the Exceptional Care Network. That's
exactly.
Global. So thank you for having me.
So how can people reach you, JP, about some of these issues? What's the best way to reach you?
Probably my website, drbrutus.com. It's probably the easiest way. I'm easy to find on LinkedIn as well. So it's actually
you're very active
hard
on
not to
LinkedIn.
find me. It's pretty hard not to find me.
That's true. I people say that with me sometimes. Oh, I'm trying to get a hold of you. What? I'm like you, drbbadia.com. It can't be any easier. So no. drbrutus.com.
Or Private Hand Surgery Montreal or Canada. It's impossible not to find me. So
that can be a problem. But you and I need some downtime, JP. I'm looking forward to we're having breakfast in Miami.
Yes, very soon.
Next weekend, right? I think.
Yes. So
the following weekend. All right.
Please order some nice weather for me, because right now there's a lot of snow here and I need to get away.
Oh, the weather has been like the network you founded, exceptional. The weather has been exceptional. So
awesome. All right. Look forward to seeing you.
All right. Take care. Bye-bye, everyone. Thank you.
Bye-bye.